other questions also. Right? Okay.
Thank you, sir.
Any questions or any doubts on this particular thing? Santi, anything you want to add?
I think he covered everything, sir. Actually, I didn't listen to him fully. I joined in a little late.
Okay,
But
okay.
I listened to you
The question was,
completely, so I think-
no, the question was hepatitis B and anesthesiologist. And
Yes, sir.
of
Yes,
course,
sir.
the candidate presented all the answers, what I told in a detailed manner, but I just modified it by dividing it into two divisions. One is the anesthesiologist getting injured and getting infected with hepatitis B. That is, previously they used to describe it as a needle stick injury and its importance in the
Yes.
protocol. And the second half is the patient whom he has to manage, who is a known case of hepatitis B infection. So
Yes, sir.
that if you divide it into these two categories, and it will be more easy to describe, and the presentation will look more appealing. That's what I said.
Yes, and he can finish all the points also within that time once you
Yes, that's
do
right.
that
Yeah,
kind of division. Thank you so much.
right. So shall we go to the case presentation?
Thank you so much,
Yes,
sir.
sir.
Thank you, sir.
Yeah.
Now, Dr. Rajesh from RH Perambur, third year post DNB, is waiting to take its practical exam, and he'll be presenting case of obstructive jaundice case.
Mm.
Over to Dr. Rajesh.
Good evening, sir.
Carry on.
Andiyappan, 60-year male coming from Kolattur, is a retired railway employee. He has come with the chief complaints of yellowish discoloration of urine for past 3 months, with nausea for 4 weeks, generalized itching for 4 weeks. Sir. History of presenting illness. Patient was apparently normal 3 months back. Then he started yellowish discoloration. Then he started having yellowish discoloration, which is of gradual in onset of 3 months duration, progressive, associated with no prodromal symptoms. Yellowish discoloration is associated with itching, pruritus, clay-colored stools, and there is a loss of appetite and loss of weight about 7 kg for a period of 3 months. Patient complains of nausea, usually not associated with vomiting, and there is a history of generalized weakness and fatigability for the past 2 months. No history of black colored stools, no history of any blood transfusion, no history of tattooing, no history of travel to endemic area, no history of any upper abdominal surgery, and there is no history of fever. Past history. Patient is a known case of hypertension on treatment for past 5 years. He was initially started on tablet Remipryl 2.5 mg BD. Then the dose has been escalated and he was added with tablet Metalor 25 mg BD 2 years ago. Now his blood pressure is very well controlled. Sir. No history of diabetes mellitus, ischemic heart disease, bronchial asthma, epilepsy or tuberculosis. History of ERCP, endoscopic retrograde cholangiopancreatogram with stenting drainage done for jaundice 1 week back under total intravenous anesthesia, sir, and it has no complication. Personal history, patient has completed primary schooling, is married, is non-vegetarian, is an ex-smoker, stopped 20 years ago, previously used to smoke 10 to 15 BDs per day for 10 years, sir. And he is an ex-alcoholic, stopped 20 years ago, and he has drank alcohol for 10 years. He usually drinks brandy around 90 ml per day, sir. And he denies any high-risk behavior. Family history, sir. No history of similar illness in the family. No history of diabetic, hypertension, ischemic heart disease or asthma, and any carcinoma in his family. No history of bad anesthetic history in relatives, sir. History summary, sir. 60-year male.
Before you summarize, did you ask anything about whether the jaundice is progressively increasing or it was decreasing in between and there was some clearance? Is it important to ask a question like that?
Yes.
Do you find that 3 months ago you noticed some yellowishness in the eye? Okay, that is how patients, when they look at the mirror, they
Yes,
find
sir.
that their eyes are looking yellow, or somebody in the family will say, why your eyes are looking little yellowish, and then they try to test, isn't it? So
Yes.
was it progressively becoming a deeper and deeper yellow hue, or whether it was clearing in between and then becoming yellowish again? What is the importance of that history?
Sir, usually in pancreatic carcinoma, there will be a waxing and waning pattern of jaundice in the day, sir.
Ah,
But for this patient, it was progressively increasing, sir. Initially he started noticing yellowish discoloration in urine. Then he saw in his eyes. Then after he got generalized itching, he noted that his skin has also become yellow color.
very good. So, okay. Then when you say the urine, what whether was the color of the urine also becoming more intense, or whether it is mild yellow all the time?
No, sir, its color was also becoming intense, sir.
Intense. So with the clay colored stool, the urine also, what should be the color of the urine if the motion is clay colored? Will it be only yellowish, or will it have a different color?
High colored.
What? Eye colored can be, even a dehydrated patient will have eye color. Will it remain yellowish, or will it turn into some other color? More like an orangish
Orange is on long
Ah.
standing, sir.
or reddish brown, almost looking like a hematuria. Okay. And what about the scratch marks? Is there any question you should have asked about the itching and scratching?
There was in inspection, I'd like to tell about this, sir. There was a generalized scratch marks all over his exposed areas, sir.
No, that is inspection, that your examination is there. But patient says his complaint is itching, isn't it? So can't you ask some question about that when the patient says, when you itch, what happens to your skin? Can't you ask a question like that? Normally, when a person gets a itchy feeling and they scratch, how will it be manifested in the skin?
Scaly marks would be there.
It will be either a whitish line, or in fair people, it may be a reddish line. Isn't the arterial rashes?
Sir.
But in a patient with suspected liver disease, why the scratch mark question is important? Instead of a white line or a reddish line, there is some bleeding every time he scratches. What does it indicate?
It indicates there is some problem with this coagulation process.
Coagulopathy. That can be identified from the history itself. So the three questions you should ask with regard to their complaint is the progressive nature of the yellowishness or waxing and waning nature of yellowishness, intensity of the urine color starting with a mild yellowish tinge to very severe orangish red color. Third is the scratch marks, whether they are simple scratch marks like white line or arterial reddish line, or bleeding from the scratch sites. Every pair, wherever he scratches, if it bleeds and then it dries up. No patient, unless you ask them, he will not tell you. So anyway, you will be finding it out in your inspection, but these questions should be asked. Okay.
Yes, sir.
Right. Okay.
Also ecchymosis,
Okay.
no, sir, when they have a spontaneous ecchymosis.
Yeah. So any coagulopathy that can, spontaneous ecchymosis also
Vitamin
can
K
happen.
deficiency.
Yeah. Yes. Right. So you can summarize your history now.
A 60-year male coming from Koluttur
Mm.
has presented with the complaints of yellowish discoloration of urine for 3 months.
What is his occupation?
Sir, he was a SSC in railways, sir.
Okay.
Senior section engineer in railways.
Engineer. So it's a desk job or a field job. He has to go for inspection to some areas where he can get infected with
Yes, sir.
some. Is it possible?
Yes, sir.
So always mention about the occupation also. Okay, to find out whether it could be related to occupational hazard. Okay, right. Go ahead.
Sir, he is presented with yellowish discoloration of urine, which is of gradual progressive duration with no waxing and waning pattern. And he has complaints of nausea for 4 weeks, generalized itching with no signs of ecchymosis or skin bleeding for 4 weeks. And he has no other issue significant no other significant history, sir. And he is a known hypertension on ramipril 2.5 mg twice a day and tablet metal 25 mg twice a day, sir. And his blood pressure is under well control.
To control. Is there any drop in blood pressure requiring stoppage of any of these drugs after
No,
the
sir, there was
development of the
no
jaundice?
history.
Is it
at the
possible
patient.
for a patient's BP to get lower if they become show signs of yellowishness? And what
Yes,
is
sir.
the reason for that?
Usually in cardiovascular, because of the jaundice, there will be SA node inactivation, so there will be bradycardia, sir. Plus,
Okay.
jaundice itself will cause
What will happen to the vasculature, SVR?
fall in the SVR will be there, sir.
So will that automatically reduce the blood pressure? So is he taking the same dose or has he again gone back and reduced the dosage? That question did you ask?
Sir.
So you should ask always, okay? Point of testing, how often he gets his blood pressure tested? Was there any reduction in the blood pressure after he started noticing the yellowish discoloration? And did it warrant any reduction in the dosage of drug that he is taking? That is a very important. It is something akin to a CKD patient who is a diabetic patient may require lesser doses of anti-diabetic medication when they go for very severe end-stage disease. Similar to that, here also, when they develop a advanced liver disease with a severe vasodilatation, their BP should automatically come down. And if they continue to take the original dosage of that, one day they may land up with a severe hypotension. Okay, so that question also you should ask that. Okay. So you have summarized the history. Now go for your examination.
Examination, sir. The general examination is weight is 55 kg. His height is 165 centimeter. His BMI is 20.2 kg per meter square, sir. Is moderately built and nourished, sir. There is no pallor. Deep greenish yellow joint is present. There is no cyanosis, no edema, no clubbing. He is afebrile. Neck veins not engorged. His pulse is 82 per minute, regular in volume. Regular and volume is normal. No radial or no radiofemoral delay. All peripheral pulses are palpable, sir. Blood pressure 117/62 millimeter of mercury in right upper arm on sitting position. Scratch marks with abrasion present on exposed body area. No lymph node palpable. No bruises or no ecchymosis. Systemic examination. Abdominal examination, sir. Inspection. Abdomen is scaphoid in shape. Umbilicus is normal. Flanks not full. No engorged vein or visible pulsations. Palpation. Abdomen is soft, non-tender. No organomegaly. Percussion. No free fluid present in abdomen, sir. Auscultation. Normal bowel sounds here. Central nervous system is conscious, oriented to time, place, and person. Motor tone is normal. Deep tendon reflexes are normal. No astraxis. Cardiovascular system, apex beat felt at the fifth intercostal space inside the mid-clavicular line. Heart sounds are normal. No murmur ears. Respiratory system, respiratory rate is 17 per minute. Bilaterally normal vesicular breath sounds here. No added sounds. No lymphadenopathy. Rectal examination, no hemorrhoids or no mass or bleeding present, sir. Airway examination is Mallampati grade is grade 2. Mouth opening is adequate, allows 3 fingers. Neck extension is adequate. Thyromental joint is mobile. Temperomental distance is more than 6.5 centimeter. No buck teeth or artificial dentures present, sir. His spine is normal.
Always include upper lip bite test in your airway examination. When you say but no buck teeth and other things, it's always better to include upper lip bite test to assess the airway. Okay.
Yes, sir.
Go ahead.
Sorry, sir. 60-year male hypertensive patient presented with yellowish discoloration of eyes and urine for 3 months with nausea and generalized itching for 4 weeks. Was diagnosed as a ILR cholangiocarcinoma after evaluation with obstructive jaundice, planned for right appendectomy with wide local excision and radical cystectomy with nodal clearance.
What is the surgery planned?
Right appendectomy with wide local excision and radical
Wide
cystectomy with nodal clearance.
Okay. So it's a cholangiocarcinoma. Okay.
Yes, sir.
Right. So is it extrahepatic or intrahepatic?
Extrahepatic, sir.
Extrahepatic. Right. So can it become intrahepatic also?
Yes, sir.
How?
Anaesthesis.
How an extrahepatic obstruction progress on to intrahepatic obstruction?
Metastatic invasions.
Metastatic invasion. Okay.
Primary biliary cirrhosis can happen and then
Primary bilirubin. Initially, will all these things will be very late. Supposing there is a cholangiocarcinoma, okay, it is outside the liver, okay, along the draining passage. What is the definition of obstructive jaundice? How do you define obstructive jaundice?
so, yellowish discoloration of eye, skin and sclera and in other tissues due to the increased bilirubin. The cause may be due to intrahepatic or extrahepatic causes can be there. Sir.
See, definition of jaundice is yellowish discoloration of skin, mucous membrane and sclera. Okay? But obstructive jaundice, the classification is extra and intrahepatic. But what is the complete definition of that? It is the inability of the bile to deliver or travel into the intestines. It is blocked there, isn't it? That is where the obstruction occurs. So the definition of obstructive jaundice is inability of the bile to drain into the intestines, resulting in accumulation of bilirubin in the blood, resulting in yellow discoloration of sclera, skin and mucous membrane. That will be, don't you think that will be a better definition than saying intrahepatic and extrahepatic, wherever it may be. Okay. So how do you normally define or classify the etiology of jaundice?
Hemolytic jaundice, obstructive jaundice, and hepatocellular jaundice, which can be classified into pre-hepatic, hepatic, and
Hepatic and
post-hepatic.
what is the main difference between pre-hepatic and intrahepatic and post-hepatic?
So, pre-hepatic jaundice mostly it's of hemolytic jaundice, sir.
Okay.
Where because of the increased breakdown of RBCs, there will be increased bilirubin
That is the
production.
cause. That is the cause. But how do you detect that?
Actually, unconjugated bilirubinemia will not be more than 4 in pre-hepatic causes, sir.
So total bilirubin is increased, but the majority is unconjugated bilirubin.
Unconjugated.
Okay?
Yes, sir.
Whereas in intrahepatic, what happens?
Hepatic conjugated bilirubin will be higher, sir.
Will be higher, but there will be unconjugated also. Whereas in post-hepatic or obstructive jaundice,
Both conjugated and unconjugated bilirubins will be high, sir.
very, very minimal unconjugated, majority will be conjugated. What is the difference between an unconjugated bilirubin and a conjugated bilirubin?
Bilirubin unconjugated has no polarity, sir, so it is not soluble in water.
First of all, what is the chemical nature of that? When you say unconjugated,
Sir,
before talking about polarity or water solubility, what should you first say about unconjugation?
sir.
What is conjugation?
Adding of glucuronide transferase.
Very good. That is the point that you have to say. When you say unconjugated, it has not been added with the glucuronic acid. Only when you add it with glucuronic acid, it will become soluble or polar and get excreted by the
Water
kidney.
soluble.
Okay. So that is the most important difference. Unconjugated and conjugated. Direct and indirect. It's another name for these things. Okay.
Yes.
Which one is more dangerous? Unconjugated bilirubin or conjugated bilirubin? Or what is the effect of excessive levels of unconjugated bilirubin and conjugated bilirubin. Which system will get affected more?
CNS.
CNS will get affected.
CNS is affected in which one?
Unconjugated.
Unconjugated
Unconjugated.
bilirubin will cross the blood-brain barrier.
So which type of patients are more prone for unconjugated bilirubin CNS involvement?
Hemolytic diseases of newborn and
Kernicterus. Okay.
kernicterus.
Very good. And conjugated bilirubin, which system it will affect?
Cardiovascular system.
More dangerous, more life-threatening. Cardiovascular system and all, it will take a long time. All bilirubin will affect the cardiovascular system.
Absolutely.
But specifically, just like CNS getting more affected in unconjugated, which system will get affected more with conjugated? How is it going out of the body, conjugated
It will
bilirubin?
reach blood vessels, sir. It will directly reach.
Blood vessel, where does it take it to? Blood vessel is carrier only, no?
Renal.
Ultimately, renal system. One of the important causes of hepatorenal syndrome is damage to the tubule by the inflammation created by the conjugated bilirubin load. Okay, so there is a vasoconstriction as well as there is a dehydration. All these things resulting in HRS. Okay,
Yes, sir.
so you have to expect more renal damage in conjugated bilirubin and CNS damage in unconjugated bilirubin. Okay, so that is a very important thing that you have to know. Right. So this patient is now posted for hepatectomy, radical gallbladder dissection, and
Clearance.
clearance. Okay. So these three things have to be done. Now he has been sent to you for preoperative evaluation. How are you going to proceed?
So I'll proceed with investigations after detailed history taking and
Okay, all the
proceed
history
with the
taking, every examination, diagnosis, everything has been done, right? Now they have
for
sent you,
investigations. Sir.
they planned for this procedure also, they have sent you. So what investigations you want in this patient?
I don't know about the patient's hemoglobin status. Sir.
Very good.
Platelet function and assay both.
What is likely to happen to hemoglobin? Will it be normal, low or high?
Sir, it might be low, sir.
Why?
Because patient is malnourished.
Malnourished. Okay,
Yes,
but
we
so
have to-
dietary, he has been having loss of weight, loss of appetite, so nutritionally it may be. So if it's a
Deficiency anemia.
nutritional cause of anemia, what type of anemia you expect?
Iron deficiency anemia.
Microcytic,
Hypochromic.
hypochromic anemia. Very good. Okay, then.
Because of
As
bleeding
per
also.
platelet function.
Any other blood test you want other than hemoglobin and hematocrit? What are the things done in the CBC, complete blood count? What all the things you do only hemoglobin or you check for something else also?
Total count. Platelet.
Total count and differential count, is it important in this case?
Yes, sir. Yes, sir.
Why?
Because these patients are more prone for endotoxemia, sir.
Not only that, infection,
Since the
spontaneous
bilirubin
bacterial
doesn't-
peritonitis is very, very common. Okay? That may be causing a elevated white cell count also. So it is not only the RBC and hemoglobin, you must check the white blood count also. Right. Then platelet you want to check. Okay.
Function and assay both, sir.
Hmm.
And then ECG, sir.
So
Electrocardiogram.
right from blood test, you complete all the blood tests and then go for the other investigations. Okay.
Last for renal function test, sir. Serum urea and serum creatinine, sir.
Okay.
Serum electrolytes, sir, last.
Other liver, one minute, Mobi. Other liver function tests, have you finished?
No, he's now going through first renal and then coming to liver examination. Yes.
Okay.
He's mentioning blood test one after another. First he has completed CBC, then he is
Yes,
going for renal function. LFT. Okay.
Liver function test, sir. Synthetic functions of liver, I'll ask for serum albumin and PTINR, sir. Prothrombin time and international normalized ratio.
Okay.
And then I'll ask for serum bilirubin, sir. Total bilirubin, direct bilirubin, and indirect bilirubin, sir.
Very good.
I'll ask for aspartate aminotransferase and alanine aminotransferase enzyme levels. And I'll ask for serum alkaline phosphatase and serum amylase levels, sir.
Hmm. What is the
I'll ask-
importance of serum alkaline phosphatase in this case?
Because of cholestatic jaundice increased bilirubin's alkaline phosphatase levels will be elevated, sir.
A
More
mere
than
elevation
3 to
of alkaline phosphatase is enough to diagnose liver
3 to
disease.
5 times of elevation of alkaline phosphatase is significant in cholestatic jaundice, sir.
Alkaline phosphatase can increase in Paget's disease also, bone diseases. So how do you differentiate between that and this?
5 times the rise in
Even Paget's disease, it can enormously increase. It is not that 3 to 5 times can increase even in Paget's disease and other bone disorders, or multiple myeloma also, you can get all these things. So how do you differentiate whether it is of liver origin or whether it is of skeletal origin? What is the other enzyme you should
gamma
always
glutamate
correlate?
transfer.
GGT, okay?
GGT will ask
Both are elevated, it is from liver. If GGT is normal and it is only a serum alkaline
Increased.
phosphatase, it can be from other extrahepatic sources, okay? That is okay. Right, then?
Then I'll ask for blood grouping and typing, sir.
Hmm.
I'll ask for serology, sir.
Serology. Any other blood tests? Very, very important.
5' nucleotidase level.
What about
The
electrolytes?
drugs that we give, all the drugs
Serum
that we give,
electrolytes.
what will happen to the drugs that we give? It'll get bound to something, no?
அது முதல்ல sold proteins he said about, I think. LFT
No,
RB,
proteins.
he mentioned about that. But electrolytes, so what electrolyte abnormality can happen?
It's a chronic alcoholic
Hmm.
hypomagnesemia, I'll suspect, sir.
Ah.
Hypophosphatemia.
What will happen to sodium and potassium, which are the two most important electrolytes in these patients? Supposing this patient, because of chronic obstruction, has gone on to some amount of cirrhosis also. Can cirrhosis happen in post-hepatic obstruction?
Yes, sir.
Yes. So what will happen to the sodium level and the potassium?
Sodium level, usually it is of pseudo hyponatremia, sir.
Hmm.
The sodium level will be normal, but because of the increased fluid, it might resemble as hyponatremia, sir.
Why these patients are usually, if they develop cirrhosis, why they are given this potassium sparing diuretic or aldactone,
Because
acylactone?
of the central hyperaldosteronism will be there, sir.
So anti-aldosterone blocking
Antagonist will be
mechanism
there.
is okay. So potassium also will be low in these patients. So you want to correct that also, isn't it? So you have to check that, very, very important. Right, then. So all the blood tests are more or less over. Next, what do you want to do? What other examination you want to do?
Ask for an ECG and a chest X-ray, sir.
ECG and the chest X-ray. What do you expect to see in them? Every investigation you mention, you should tell why you want that particular investigation.
Sir, cirrhotic cardiomyopathy. The patient has gone for cirrhosis, he might have cirrhotic cardiomyopathy, sir.
Okay.
And the patient might have portopulmonary hypertension. So in that there can be a right ventricular pressure higher. So RVH strain can be there, sir. Direct sinus bradycardia will be there, sir, because
Very
of
good.
increased bilirubin. And since patient is
Supposing
known
instead of
hypertension,
bradycardia, supposing patient's heart rate is 120, how do you explain that? The patient with severe jaundice, you take an ECG, normal effect of high bilirubin on the SA node, you said is it is going to block the conduction and produce a bradycardia. But instead of bradycardia, if the patient's heart rate is more than 110, 120, what does it indicate?
maybe because of the fall in SVR hypotension.
Heart failure. Patient has
Heart
gone on to heart failure to compensate He has over, so that is one of the important points given in Miller. A tachycardia in a patient with severe jaundice should tell you that he is in underlying heart failure to compensate for that. Okay, so that's a very ominous sign that you should not take up that patient just very lightly and take him up for surgery. So, but heart rate should be always less than 80 in a patient with jaundice. If it is even more than 80, you should suspect an underlying heart failure in those patients. Okay, right. So ECG is over. X-ray chest. What do you find in X-ray chest?
The patient, patient is on fluid overload ascites. I'll ask, there can be pleural effusions can be there, sir.
Okay, very
And
good.
then because of the hepatopulmonary syndrome, there can be increased intrapulmonary vasodilations can be seen, sir. Pulmonary vasodilations can be seen.
What is orthodeoxia?
Sir, patient feels breathlessness on from lying down to standing up, sir.
In the erect posture, patient feels
Patient
breathless.
develops breathlessness.
Normally, patients will feel better if they have a congestive failure. They are not able to lie down. Once they sit up, they feel better because of the decreased venous return. Whereas here, patients find it difficult to sit up rather than they are comfortable lying down. Why it is happening that? What is the reason?
Sir, because of the intrapulmonary, there will be a respiratory hypoxemia will be there, sir.
Why
Because of standing hypotension will be there, so the hypoxemia will get aggravated, sir.
What is this? There are two differences, no? One is hepatopulmonary syndrome, and next is the portopulmonary syndrome, right? In hepatopulmonary, what happens? What is the shunting? What happens? There's a shunting, isn't it?
Increase pulmonary vascular pressure will be raised, sir.
So intra-alveolar shunting happens. Okay? So
ventilation
shunting
will be there, sir, but perfusion will be reduced.
So there is a hypoxia which makes them breathless. Okay, right. Can they have a picture like ARDS in X-ray if it is a very advanced case? And why it can happen? What happens in ARDS actually?
Sir, 3 stages of ARDS are there, sir.
Exudative stage.
Proliferative phase, inflammatory phase, and fibrotic phase, sir.
First is exudative phase.
Exudative.
Then only you have the proliferation fibrosis. So that, okay. So in liver disease also, this can have a picture like ARDS. One of the non-pulmonary causes of ARDS is liver disease also. Okay. So you can, in advanced cases, you can get a picture like what is the description for ARDS X-ray chest? What type of opacity you will get?
Ground glass opacity.
Ground glass opacity. Okay, you always, so suddenly the question may jump like this from liver to respiratory system. You should be able to think fast and answer. Okay, right. So you have finished X-ray, you have finished ECG. What else you want to do?
I want an echocardiogram.
Echocardiogram to find out the cardiac function. Okay. What any specific defect you want to look for in echocardiogram?
Pulmonary artery pressures also I look for.
Pulmonary artery pressure. Okay. Any other silent killer? Can the cardiac muscles relax like normal muscles in cirrhosis? Will the diastolic function be normal?
No, sir. Diastolic dysfunction.
So, diastolic dysfunction is very, very common, which may be a silent killer. Okay, so you have to specifically look for the diastolic dysfunction. Okay, right. So that is also done. Okay, all the investigations. You want any other investigations? Not much. Okay, right. So all the investigations are done fairly okay. Now what is the next step?
So, after the patient has been posted for surgery, preoperative assessment, pre-medication, sir.
What you have done is preoperative assessment only with all the investigations, but before pre-medication and completion of assessment, any stage is there?
This is stratification and optimization.
That is always a very important step. No, you should never forget risk stratification. So what are the methods of stratifying the risk? This case in liver disease patients.
Two methods are there, sir.
Eh?
Two methods of risk stratification can be done, sir. One for survival, sir. One for whether we can choose whether the candidate is for liver transplant or not, sir. First scoring is child's Turcot butt scoring, sir.
CPT scoring.
CPT scoring, sir. And another is a model for end-stage liver disease, sir.
So any other than the two scoring, do you know any other scoring system?
Pediatric end-stage liver disease, sir.
Pediatric?
End-stage liver disease and adopt LC scores.
What is adopt LC score?
What is operative treatment in liver cirrhosis, sir.
So what are the criteria for that? Because commonly all people will be able to say everything about CPT and MELD scoring system. But this adopt LC is becoming more popular now. What is the importance of this adopt LC score?
Ask for age and the CTP score, sir. And Charleston's comorbidity index. I'll ask for cardiac, all other renal and every system enrollment, sir. And the duration of anesthesia. If the duration is more than 3 hours, it is an high risk.
So based on all these things, what do you assess?
Sir, patient undergoing for surgery, I'll assess for the risk of
mortality.
Mortality.
So the number of points that the scoring gets, as the number increases, the mortality also increases. Okay. So these three scoring systems you should do and assess the risk. And how do you optimize once you assess the risk? What are all the things that have to be optimized generally?
Serum bilirubin has to be reduced, sir.
How do you reduce that?
For this patient, ERCP stenting has been done, sir.
Already been done. Very good.
Then I'll add tablet cholestyramine, 300 mg TDS tablets.
How does it help? Cholestyramine, how does it help in reducing the bilirubin?
It reduces bilirubin absorption from the intestine, sir. Competitively, it inhibits absorption.
Bilirubin, is it getting?
No, sir.
Are you taking bilirubin in your diet? Get it block the absorption?
Prevent reabsorption, sir.
Reabsorption. Okay. Okay. Right then. So okay, bilirubin.
Coagulation profile optimization, sir.
That is a very, very important thing, isn't it? So you must assess the bleeding time, clotting time, and try to correct the deficiency, because vitamin K dependent clotting factors may be deficient. Okay, so always you must do the pre-treatment with vitamin K. How much you will give and by what route you will give?
10 mg IM for 3 days, sir.
IV cannot be given?
Yes, sir. Rapid correction on treatment is
IV also can be given. Okay, right. Then any other correction to be done?
Actually, there's a lot of controversy now about IM injections in patients who are suspecting to have a coagulation disorder.
Coagulopathy. That itself can produce a hematoma or something like that. Okay? So always I prefer to go for an IV.
Slow IV.
Any other correction?
Electrolytes correction I will do, sir.
Okay. Any albumin correction to be done if it is low? Synthetic function.
If hypoalbuminemia is there, I'll correct albumin, sir.
Okay. Right. So
renal status to be assessed. Also the output and the hydration status.
Yeah. That has to be taken as a part of the treatment. More than optimization, patients sometimes may require preoperative IV infusions also if their renal output. So What is the aim of maintaining renal function? How do you maintain the renal function intra and post-op in these patients? How many ml of urine you should get per hour minimum?
0.3 to
Normally we aim for 0.5 ml per kg per hour. Okay, whereas in these cases it's always a standard better to go for at least 50 ml per hour. Okay, the minimum of 50 ml and more than that it's ideal. So keep the kidneys always flushed nicely, make them work. Otherwise there is a possibility of shutdown. ATN and acute kidney injury is very common in these patients. Okay, right. So all these optimizations are done. What pre-medication you want to give?
medication tablet pantoprazole 40 mg I will give, sir. Night and morning on tablet, sir.
Okay.
The patient is very well conscious and no signs of hepatic encephalopathy. I'll give minimal benzodiazepines, sir.
Okay.
Say,
NPRs
better to say instead of saying minimal benzodiazepines, you can say short-acting benzodiazepine or an anxiolytic. Yeah. Minimal benzodiazepines, and maybe I will ask you, can you give diazepam? Instead of giving 5 milligram, can you give 2.5? I've been kept on it.
No, madam. It's long acting and oil
So
solid.
midazolam is available now for oral also. So you can
Syrup is
always,
also.
you can go for that, right? Water soluble and easily eliminated. Right then.
Inform about the NPO status, sir. Blood reservation, blood and blood products reservation, NPO, and I'll get an informed consent from the patient. And the patient is conscious, I will get from him, or else I'll explain it to the relatives and I'll get confirmed. I'll get the consent from the relatives, sir.
So you will operate on an unconscious patient also? You said consent. So mostly we try to operate on a stable patient only. Okay, if he's already gone on to encephalopathy and coma stage, what is the point in operating on that patient? You will have a definite 100% intraoperative mortality. Okay, so that is why we do the risk stratification. So we have to select the patient correctly and do it. Okay, okay, go ahead. இந்த மாதிரி தப்பா நடுவுல போய் ரிலேட்டிவ் கன்சர்ன் வாங்கிட்டு அன்கான்சியஸ் பேஷண்ட் ஆப்ரேட் பண்ணலாம் சொல்லிடக்கூடாது எக்ஸாம்ல. ஓகே, ரைட், கோ ஹெட்.
Next on the day of surgery, sir.
What are the intraoperative management? What is the monitoring you want? How you manage the intraoperative period? That is all the thing that you have to describe now.
Monitoring, sir. Monitoring, I'll connect ECG, blood pressure monitoring, pulse oximeter. Then
these are all standard monitoring. You can say I will attach all the standard monitoring. Any special monitor you require? Other
blood pressure monitoring, I'll put an arterial line for frequent ABGs and invasive blood pressure monitoring.
Because this is a very extensive surgery, likely to have a lot of fluid shifts, so better to have a invasive line with a beat-to-beat monitoring of blood pressure, which will help also to measure the or analyze the ABG, electrolytes, everything periodically. Very good. Okay, then you want a central line?
Yes, sir, central line.
What is the need for a central line in this case? What is the risk of central line?
Sir, risk of hematoma and bleeding is there if there is a coagulation defect, sir.
Very good.
I want a central line for monitoring and infusions, sir.
Vasoactive drugs.
Infusions.
Very good.
And
okay.
Rapid fluid administration also I use.
So two purposes for central line. One is for rapid fluid replacement and vasoactive drugs. Second is to monitor the volume status. Okay, right. Okay, agreed. Go ahead. So what are the drugs that are preferably used in these cases for induction, relaxant, maintenance, analgesia, extubation? These are all the 5 steps. Okay. So which is the ideal induction agent?
Ideal induction agent is propofol, sir.
Why?
It has extra hepatic elimination in lungs and reticuloendothelial systems and kidneys, sir.
Very good. Also, And any other advantage? So it is
Short
not
acting, sir.
purely short acting. Recovery profile is much more clearer in patients with propofol. There is no residual or hangover effect is not there. Okay, so apart from the elimination route, the recovery profile is also very, very important advantage. Right.
Yes,
Type
sir.
of
Pardon?
opioid.
Opioid.
Analgesic opioid, which to prefer, sir?
We have not come to that stage. We are now in the induction stage itself. So induction agent of choice is propofol. Can you use etomidate for induction?
No, sir. It will cause adrenocortical suppression.
Suppression. Very good. Okay. So ideal agent will be
Also
ketamine.
propofol.
No, sir.
Also, who is taking also propofol? What is that? Right. What about ketamine? Supposing patient's BP is only 90/70 at the beginning. What will you do? How can you correct that hypotension? Is it normal? Supposing he has been maintaining only 170, 90/70 in the ward and he has been
Yes, sir.
quite comfortable with that. What will you do? Can you go ahead with the propofol induction? Can propofol lower the BP further?
Yes, sir. It will cause fall in further SVR fall will be there, sir.
Okay, so then how to manage that? A patient with a low BP at the beginning of the surgery, you want to use propofol because of its advantage, but it can cause hypotension also. So what are the methods of correcting that, avoiding that hypotension and still use propofol? What are the options for you?
I'll adequately
Ketofol.
preload, sir. I'll
Adequately
preload the
preload.
co-loading. I'll also do, sir. Or I'll start ionotropes during
Co-induction.
And go for a combination of half the dose of propofol and half the dose of ketamine.
Ketofol induction I'll do, sir.
Ketofol is one thing, or you can go for a phenylephrine induction along with the propofol. Okay, so phenylephrine either an intermittent bolus or an infusion also can be started simultaneously, and still you can go ahead and do the induction. Okay, that's always an accepted method of induction. Okay,
Okay.
right. So what is the relaxant of choice?
Sir, relaxant, I'll use atracurium and cisatracurium, sir. For rapid, because it undergoes Hoffman elimination, sir. So I'll use atracurium and cisatracurium, sir.
Okay.
Choline usually can be given till if the neutral cholinesterase level doesn't fall very much, sir. For rapid sequence intubations, choline can be used, sir. Other than that, atracurium and cisatracurium I'll use, sir. Analgesics, I'll avoid morphine because it is mainly metabolized in liver and it is eliminated via kidney, sir.
Okay.
So I will use fentanyl with titrated boluses and multimodal analgesia with assisted, whenever possible, local anesthesia technique, regional anesthetic techniques will follow, sir.
So this
multimodal
surgery, you know what is the surgery is going to be done. You know that is a hepatectomy, radical gallbladder dissection, and extensive clearance surgery. So, what ideal regional technique you can combine with the general anesthesia?
The coagulation profile is under well controlled. Then I will plan for a thoracic epidural, sir.
Very good.
Blocking from T7 to T11 levels. I'll keep depth around T7 to T11 levels, sir.
Very good. Any other method?
Tap, the subdiaphragmatic tap block can be given, sir.
Paravertebral?
Paravertebral can be used. Rectus spinae block also.
Rectus spinae block also is very, very commonly done for abdominal and thoracic surgeries. Okay,
Yes.
right. Okay, so you can go for that. What about the maintenance of anesthesia?
So, maintenance of anesthesia with the sevoflurane.
Can you use nitrous oxide?
So if there is a pulmonary hypertension, I'll avoid nitrous oxide, sir.
So air oxygen mixture with a volatile, either sevoflurane or isoflurane. Why these two agents are preferred?
So
Why not desflurane? Why not halothane? Why not?
Halothane will cause arrhythmia, sir. It causes, elimination is also made by hepatic. It might cause halothane hepatitis, sir. So it
What
is
are the
avoided.
types of halothane hepatitis?
Type 1 and type 2, sir.
Very
Two
good.
types are there, sir.
What is type 1 and what is type 2?
Type 1 is due to the immune complex deposition, sir.
Is
Type
it type
2 is
1
due to
immune complex?
deposition, sir.
Is it the type 1 or is it immune mediated? Or type 2 is immune mediated? Type 1 is non-immune mediated. Type 2 is immune mediated. Hapten formation and immune mediated. Okay. Will it occur in the first exposure itself?
No, sir. Within the 3 months of previous exposure, it might re-exposure within the 3 months of previous exposure, it can occur.
So halothane hepatitis to happen, you require repeated exposures. Okay. So it is not possible with the first exposure. Okay. But why we want to avoid halothane? Because it is hepatotoxic. And already the liver is damaged. Okay.
Damaged.
So you don't want to use hep. So don't worry about halothane hepatitis because once single exposure is not going to cause the problem, but because it is a just like your cardiac depressant, renal depressant, it is a hepatic depressant drug. So we don't want to use that. Okay, that is the reason, right? Okay. And what is the advantage of using CO or isoflurane?
Sir,
What is the thing that they preserve?
sir, they preserve hepatic blood flow, sir. Sir,
Hepatic blood flow. What is the what is the unique nature of hepatic blood flow?
it has dual blood supply, sir.
Very good.
There is an 75 to 80% is from the portal vein and 20 to 25% is from the hepatic artery, sir. And it has an hepatic arterial buffer response, sir. So whenever there is a fall in the portal blood flow, the hepatic artery usually compensates for the loss of blood flow, sir.
So the blood flow
Mainly due to the nitric oxide and adenosine mediated vasodilation of the hepatic artery.
Okay. So this response is preserved with the sevoflurane and isoflurane. Okay. That is the answer. So HABR, hepatic arterial buffer response, is preserved by CO and isoflurane. That is why they are the drugs of choice even for liver transplantation also. Okay. Right. So you want to use oxygen, air, sevoflurane and isoflurane, any one of them as an inhalation agent for intraoperative use, right? Along with some regional block, whatever you prefer. What are the intraoperative problems you should anticipate because of the surgery?
Sir, surgical handling of liver might reduce the hepatic blood flow, sir.
Okay.
So minimal handling and laparoscopic abdominal distension also reduce hepatic blood flow, sir.
Okay. Such extensive dissection, what is it likely to cause?
Bleeding, sir. Severe bleeding.
Hemorrhage. Already there may be some amount of coagulopathy with all that, the hepatic resection, the wide excision, all these things are going to cause more bleeding. So you should anticipate blood loss and blood products all should be kept ready. Okay.
Yes.
Okay. Is it a major exposure of the abdomen or a minimal exposure?
Major exposure, sir. So
So
they are more prone for hypothermia, sir.
hypothermia is very important. Okay. So how do you manage the hypothermia component of this?
Warmed IV fluid, sir. Forced air warmers.
How does the forced air warmer help? What is the mechanism of working principle of a forced air warmer?
Sir, conduction.
Is it conduction?
Heat conduction, sir.
Is it heat conduction? Directly do you heat the skin?
No, sir. It prevents evaporation of further evaporation.
Prevents further evaporation. You are using it in your hospital regularly, isn't it? So how does it work? You cover the patient's exposed parts with the blanket.
Prevents insensitive,
Huh?
sensitive skin. Prevents insensitive loss, heat loss.
So it doesn't supply any heat at all to the body, is it? You said forced air warmer. So a warm air is circulated in the blanket between two layers, and that is transferred to the patient by convection. It works by convection, not by conduction. Okay, conduction is direct contact. Here it is only by convection. It is heating the air that is on top of the patient's body. Okay, so it is working by convection. And IV fluid warmer. What are the instruments or equipments that are there for IV fluid warming?
Rapid,
What type of equipments are there?
rapid infuser, it will itself.
Uh?
Rapid infuser, sir.
Rapid infuser is for fast infusion.
It will also.
But also, yeah, but it will also be, but what are the mechanisms of warming the fluids?
Water bath. Heat
Water bath, that is for nebulization or humidification, water bath.
Right warmers.
Heat
and,
pump.
Coaxial warming. Okay. Level 1 infuser, they have what is called one direction, the hot water will be flowing and the fluid will flow in the opposite direction. So it is called the coaxial or lifeline warming. Earlier it was a hot plate through which the tubings were passing through between two hot plates. Okay. And they were heated to 37 degrees and that heat was conducted to the tubing and the fluid was getting warmed. That has now become obsolete because it can compress, that can block. So nowadays we have got this coaxial circuits which have the water, hot water flowing in one direction and the fluid coming out in one direction. Okay, so that is where the fluid warmer is. Have you seen one like that in your hospital? Do you have that? You have not seen, right? Okay. So hypothermia, bleeding are the two important things, and the preservation of renal function. So to preserve renal function, do you have to do anything extra other than hydration in a patient with severe jaundice? To prevent the so-called hepatorenal syndrome, can any drugs be used?
Sir,
Anesthetic
terlipressin
system can be used.
Simplest, you can use mannitol, then you can use Lasix, then you can go for terlipressin. What is terlipressin now that you have committed yourself? What is terlipressin?
vasopressin analog, sir.
Vasopressin analog. Okay. Synthetic analog of vasopressin.
Vasopressin.
What is the other name for vasopressin? What does vasopressin do?
It will cause vasoconstriction of the portal venous circulation, sir. Portal venous cells, it will cause vasoconstriction, sir.
Okay, but how does it help in kidney function?
Because of the
Afferent
reflex
arteries.
vasoconstriction, there is a reduce the effective circulatory blood volume in renal flow, sir. Thereby reducing, thereby causing portal venous vasoconstriction. It will augment the renal blood flow, sir.
General systemic blood flow will increase. Okay, right. Okay. So these three drugs can be used commonly. You can give how much of mannitol you will give and what percentage of mannitol you will use as a protective mechanism for kidney function to keep the kidney in a good diuretic phase. What are the various percentages of mannitol you have in the market?
20%.
10, 20, 25, 10% and 25% mannitol are there. Okay, so 10% mannitol, 0.5 grams per kg body weight you have to give. Okay, so that is the dose for mannitol, which you can give as a prophylactic treatment for preventing ATN or acute shutdown. Okay? And also some people use Lasix. Right. So this the third thing is this problem you have to take care of. Right. So by preserving the blood supply, you can preserve whatever function of the liver is left behind. So that is a very important thing that you have to preserve the blood flow. Right. So what are the post-op problems? And
Post-op, there might be a further progression in liver damage, sir.
So
And
how
then
will it
there is
exhibit? Supposing the surgery has caused further damage to the liver, how will it exhibit post-operatively? Which system will get affected the most?
coagulation profile, sir.
Coagulation
recover?
profile.
Will he recover?
Central nervous system, sir. Central nervous
CNS.
system.
CNS. That is the most sensitive system. Okay. So patient may develop encephalopathy. Okay. So various grades of encephalopathy can happen. He may come out in a very restless way, or he may come out in a very deep sedated phase, no response. Okay. So central nervous system will reflect the damage, further damage to the liver. Okay. More than your coagulopathy or renal shutdown, this is the most dangerous thing that can happen to the patient. Okay. Right. So how will you decide whether you can extubate the patient on table or you have to go for a elective ventilation after surgery? In other words, after a liver resection surgery, what are the criteria for deciding elective mechanical ventilation or allowing spontaneous respiration and extubation on the table? Normally, nowadays, after even a liver transplant, do they prefer to ventilate the patient or extubate the patient on the table? Any idea? They don't want to ventilate, just like your fast tracking in cardiac surgery. Nowadays, liver surgery is also becoming more and more common. So people prefer to extubate the patient. If you read the latest Miller, they say they plan to extubate on the table because the complications of ventilating and putting the patient on mechanical ventilation are more compared to. So if all the parameters are okay, then you can even safely extubate the patient. If the pain relief is adequate and patient is breathing normally, you can safely extubate on the table itself. Okay. So for that, you must decide what is the amount of blood loss that happened and how much of blood replacement was done. That is number 1 point. So hemoglobin should be adequate and patient's pain should have been controlled well. Patient should be able to breathe comfortably. The tidal volume that is generated at the end of the procedure decides the pain relief. So if the patient is pain free, he is going to breathe normally. If he is going to have pain, he is going to hold the breath and not breathe normally. Okay. And if the temperature is normal and consciousness is well oriented and able to obey commands, these 4 points should tell you that you can safely extubate the patient after reversal. Okay. So conscious state, hemoglobin, the body temperature, and pain relief. These 4 things have to be taken into consideration for deciding extubation of the patient. Okay. Right. Okay. Supposing this patient had a blood vomiting before surgery, what does it mean?
Portal hypertension, he might have developed esophageal varices, sir.
Varices, very good.
Ruptured varices can bleed, sir.
Very good. So how do you manage acute hematemesis in a patient with liver disease?
First, general management, sir. First, give IV fluids, IV fluids and resuscitation, sir. To prevent further bleeding, medical management and surgical management are there, sir.
Very good.
Medical management, I'll add vasopressin. I'll give vasopressin, sir.
Vasopressin or some other drug, some other hormone secreted by the pituitary.
Octreotide, I'll give, sir.
What is that? Octreotide is not secreted.
Somatostatin analogs.
Somatostatin. Yeah, that is the name, hormone name. Octreotide is the commercial name. Okay. Pituitary does not directly produce octreotide. It produces somatostatin, which is marketed after manufacture in the pharmacy as octreotide. Okay. How does that somatostatin help?
Sir.
What is the mechanism of its action? All of us know that we have to give somatostatin, IV, isn't it? IV or IM? IV as an infusion mixed with the IV fluids, isn't it? But what is the mechanism of action? Again, you have to reduce the pressure, isn't it? Same thing, just like your vasopressin, it also has a reduction in the portal pressures so that there is a reduction in the venous pressure and also some vasoconstriction occurring at the varices and causing the reduction. So that's a medical management, okay? What is the surgical management
Sir.
or interventional management?
Band ligation. Sir.
Huh?
Use of endoscopic band ligation.
Endoscopic ligation, band ligation or
Sclerotherapy can be given. Sir.
sclerotherapy, injection of a sclerotherapeutic agent. Okay, right. What is the old time treatment for this? What tube was used? Have a historical interest. Nowadays it is not used anymore.
Blackmore balloon tube, sir. Step.
Sengstaken Blackmore tube.
Blackmore
Sengstaken. Sengstaken Blackmore tube. So you won't fail because of not telling that, but some examiners are very fond of history. So they may suddenly ask you what is the, so what is the mechanism of that particular tube being used? How does it help?
Sir, it has 3 balloons, sir.
Hmm.
The patient mostly has to be under general anesthesia, sir, because the tube is of bigger size.
Hmm.
And, it has first tube, after endoscopy, the gastric tube has to be pulled in, sir, and it has to be inflated with 100 ml of air. If the pressure is more than 15 mmHg, then it is supposed to be an esophagus, sir. So we will have to push the tube further into the gastric port, sir. And we will have to inflate about 450 ml of air, sir. Then we will have to pull the tube out till it is stuck at the lower end of esophageal gastric junction. Then I'll pass the esophageal tube and I'll inflate the pressure, sir. Maintain the pressure of about 30 to 40 mmHg and I'll aspirate the gastric port if there is any bleeding or not. If there is no bleeding, then I will keep 12 hours continuously, sir. Then over a period of
Just
time,
what does it do actually when you inflate the cuff and all that?
it reduces the variceal blood flow, sir.
Tamponade. It's called
Tamponade.
tamponade. So it just causes a compression. That's all. Okay. So sometimes when you release the compression and tamponade, it may again start bleeding. Okay. So by the time your drugs are expected to take charge of the bleeding, so that was the treatment that was available. What was the old time surgical treatment for refractory bleeding in spite of all these pharmacological and mechanical methods of trying to stop the bleeding? What was the old time surgical treatment before the advent of endoscopy? Transection and resuturing of the esophagus. So they opened the abdomen, pulled the esophagus down, cut it and then resuture it to discontinue, make the varices continuity is disrupted. Okay, so transection and resuturing of the lower end of esophagus was the surgical treatment that not done anymore. Just like your Sengstaken Blackmore tube not available or not used, this surgery is also not done, and endoscopy is revolutionized the treatment. So you can go for banding, you can go for sclerotherapy, and you can manage any amount of bleeding. Okay, so that is a thing that you have to remember. Okay, good. So that will complete the discussion. Any points left out, Vasanthi?
Sir, I think you did everything, sir. Except this topic, I think you covered everything, sir.
Yeah. All of you have seen the PPT that Dr. Kamachi posted in the group earlier. Should I repeat it or shall we? If you have all seen, I don't think it needs a repetition, or if you are willing to see that, I'll just go through that rapidly. Okay? Kamachi?
We can repeat it, sir.
Okay.
Rapidly. That will
Sir,
enhance
I'm
our
not,
memory.
sir,
Huh?
sir, I'm
Huh?
not seen, sir. Reporting, sir. I have not seen, sir.
So, near Virupam, I'll post it.
Thank you, sir.
Yes, sir.
Right. I think this is visible now.
Yes, sir.
Right. Okay. I'll go for full screen. So this is actually a preparation on DLCD and cirrhosis, but all the features are more or less same, and I have added a few slides for obstructive jaundice also, the later half. So patients may present with the following complaints, whether it is a decompensated liver disease or cirrhosis or your obstructive jaundice. The features are more or less the same. Malaise, fatigue, loss of appetite, progressive distension of abdomen is more common with patients developing cirrhosis rather than your obstructive jaundice, unless it is an extreme degree of obstructive jaundice, which also has resulted in a cirrhosis. So if the patient has started developing abdominal distension, there is some amount of cirrhosis has already set in. That is the indication. As long as cirrhosis has not set in, it will not cause any distension of abdomen. And vomiting of blood also is an indication of portal hypertension and variceal bleeding. But easy bruising is an indication of coagulopathy. And edema legs, tremors in the hand, they are all indication of central nervous system involvement. Testicular atrophy and gynecomastia, classical of cirrhosis, poverty above and prosperity below. And changes in the color and of the palm pruritus, jaundice. So jaundice may not be there in cirrhosis all the time. Similarly, jaundice may not be there in what is called the intermittent obstruction. If the obstruction gets relieved, especially in stones, which migrate from one position to another, sometimes patient may have jaundice for 2-3 days, then automatically it may get cleared. That is why I asked him to whether he asked the question of whether it is a progressive jaundice or whether it was waxing and waning. So that itself will tell you the nature of obstruction, whether it is a permanent obstruction or a intermittent obstruction. And tortuous swelling around the umbilicus, which is the caput medusae, the dilatation of the vessels. And in cirrhosis, the patient will always have a history of chronic alcohol abuse. But not all alcoholics land up with cirrhosis. The reason we will see little later now. So these are all the exhibitions of xanthoma, jaundice, spider angioma, gynecomastia, ascites, edema on the legs. So all these things already, and skin pigmentations, all these things are the features. Now, while history taking for cirrhosis and DCLSD, you must ask for alcohol consumption because that is the most common etiology for cirrhosis in our country. Next is nutritional. Third is other conditions like chronic hepatitis also can produce cirrhosis, or the obstructive jaundice also can result in cirrhosis. But they are all quite rare. Alcohol cirrhosis is more common both in Western countries and in our country now also. And history of blood transfusion, IV substance abuse, tattooing, and these are all for hepatitis reasons. High sexual behavior, all this what we saw in the earlier presentation. And travel history, drug intake, some drugs also, chronic intake of some drugs like fungal, antifungal agents and sulfonamides, all these things also can affect and phenothiazine group of drugs overdosage. All those things can produce liver damage. And any family history of liver diseases, obesity produces steatohepatitis or fatty liver, which can turn on to cirrhosis. And it can be lack of nutrition, which is nutritional cirrhosis. And causes can be alcoholic, post-necrotic, primary and secondary biliary, and non-alcoholic steatohepatitis, hemochromatosis, excessive deposition of iron, Wilson's disease, and alpha-1 antitrypsin deficiency, which is a congenital problem. So all these things also can produce cirrhosis, and the phases of cirrhosis can be in a compensated state where the liver function is still preserved. The liver has got a beauty because it is an organ which can regenerate very well. So if the patient who was an alcoholic developed features of cirrhosis and completely stopped drinking, the liver can regenerate and become compensated. But still you will call him as a cirrhotic patient. If you see the texture of the liver in ultrasound or biopsy, it would have developed some features of cirrhosis, but then he would have been fully compensated with a normal liver function. But if he continues to booze and then abuse his health, then it will go on for decompensation. So I remember the various systems involved by this mnemonic, chief ranges, CVS, that is the decreased SVR, increase in cardiac output, and there is a hyperdynamic circulation. H stands for hematology, where it can be anemia and coagulopathy. Immune deficiency is there, so spontaneous bacterial peritonitis and sepsis are very common. Fluids, it can be hypo or hyper volume status. It can affect the renal system and the respiratory system. Respiratory, you have to remember the hepatopulmonary syndrome and portopulmonary hypertension, orthodeoxia, pulmonary hypertension, and in renal, most important is hepatorenal syndrome. Acid base and albumin, patients peculiarly have respiratory and metabolic alkalosis is very common, and there is a decreased albumin. In the nutrition, patient will have anorexia, loss of weight, impaired absorption of food materials. And in the GI tract, he will have esophageal varices, constant nausea, jaundice, and hypoglycemia is very, very common because of lack of glycogen stores. And encephalopathy and flapping tremors in very advanced cases. Mostly in acute liver failure only you get encephalopathy. But in chronic diseases of liver, if there is a sudden bleeding or an intercurrent infection, then they can go in for encephalopathy. Otherwise, or a heavy protein intake meal, all these things can produce an encephalopathy in them in chronic. But in acute, we in fact decide the severity of acute liver damage by the encephalopathy, how soon it develops after the jaundice is noticed. Within 7 days, within 28 days, within 3 months, like that only we assess the severity of acute liver failure by the development of encephalopathy. And in the skin, you will have pruritus and petechial hemorrhages. So this is the normal liver you are seeing here, which becomes little fatty because of steatosis, and then it gets inflamed. Once this very steatosis is just a deposition of fat. Steatohepatitis, it starts reacting to that excessive deposition, then becomes fibrosed, then it becomes cirrhotic. And the cirrhotic liver, if it remains for a long time, it can turn on to carcinoma also. So carcinoma can develop in a cirrhosis also. And the ethanol pathway, there is a major pathway by where the aldehyde dehydrogenase converts ethanol into acetaldehyde, which is transferred to the mitochondrium of the hepatocytes, where it is converted to acetate. And there is another pathway in the peroxisome where catalase is an enzyme which helps to convert that. And similarly, there is an endoplasmic reticulum where conversion also happens. All these things ultimately result in the entry of acetate into the bloodstream, which is going to cause all the problems. So the hepatic blood supply question is very commonly asked. It has got dual blood supply, which Rajesh answered very well. So you have 85% from portal vein, which is not a fully oxygenated blood, whereas the main oxygenation comes from the hepatic arterial supply, which is 95% saturated. And this hepatic arterial flow will increase whenever there is a decrease in the portal venous flow, but the reverse cannot happen. That is the beauty of the hepatic buffer artery. That is why it's called arterial buffer response, not a venous response. So if there is a fall in hepatic artery due to systemic decreased blood pressure, portal venous flow will not increase. So only when the portal venous pressure decreases and flow decreases, artery will dilate and it will increase the blood flow. And similarly, the factors controlling is another theory question which can be asked. It can be divided into intrinsic based on autoregulation, hepatic arterial buffer response and metabolic, or it can be extrinsic, which can increase the blood flow in acute hepatitis, supine posture, beta adrenergic stimulation and glucagon. All these things can increase the blood flow. Whereas hypoxia, hypotension, hepatic cirrhosis, upright posture, hypercapnia, beta blockade, angiotensin 2, all these things can decrease the blood flow. And portal vein, it has got only an alpha receptor, the vessel, whereas the hepatic artery has got both alpha and beta receptor. That is why it can dilate and constrict. And the importance of this is the dopamine, dobutamine and noradrenaline can act only on the hepatic vessels. They cannot act on the portal vein. So there is no systemic drug which can be applied. Now coming to the histology of the liver is very important. You have three types of lobules. One is the classic hepatic lobule, which is hexagonal with a central vein and the portal triad on the 6 corners. This is the classic anatomical description of the hepatic lobule, which drains blood from the portal vein and the hepatic artery to the central hepatic. So the direction of flow is here from periphery to the center. Whereas the portal lobule is mainly to describe the bile flow from the hepatocytes to the bile duct. So this is a triangular shape. These are all imaginary things to describe the function. So in the portal lobule, it is a triangular connection connecting the adjacent 3 central veins. So bile which is formed from the hepatocytes, they all drain here to go and reach the biliary canaliculi, which are situated in the corner. Okay. So this is the portal lobule. Then the portal acinus is the one which is important for its metabolic function or the enzymatic function. So it is a sort of diamond shaped imagination where you have the portal triad on either side, and there are 3 zones. This portal triad is related to the blood flow is going towards the central vein. So the zone which is very close to the portal triad is called the zone 1, where the maximum oxygen is received. The second zone is zone 2 and the third zone is farthest away. So in any hypoxia or hypotension, this zone 3 will be the first affected. So because they are the least oxygenated ones, and this knowledge is very important. So remember the 3 lobules: classic hepatic lobule and portal lobule and portal acinus. Then physiological functions of the liver. One important function we should always remember is it acts as a blood reservoir. So in any emergency, we all know that the liver can supply up to 1.5 liters of blood by squeezing itself into the circulation to maintain the volume status. Then the glucose homeostasis, all the fat proteins are all metabolized, drug and hormone metabolism, bilirubin formation, excretion, and immune function, because it produces all the proteins which are involved, like complement proteins, acute reactant proteins. All these things are produced in the liver. So the antibacterial action is very important. As a reservoir, it can supply up to 10% of the blood volume, and also auto transfusion in central circulation, which are all under neural and humoral control. And glucose, it is main storage of glycogen for supply, and lipid metabolism, all the cholesterol formation and triglyceride, all these things are done here. And protein metabolism is very important. Deamination of all amino acids and synthesis of most of the proteins except gamma globulin and factor 3, 4 and 8. All the other things are all produced in the liver only. And the other plasma proteins which are produced other than the common ones are coagulation factors, hormones, IGF, thrombin, esterases, complements, CRP. All these things are produced in the liver. The cardiovascular effects of the bile salts are, they produce bradycardia as a direct effect on SA node, impaired cardiac contractility, impaired response to beta agonists, and decreased peripheral vascular resistance. So the next result will be hypotensive patient prone for circulatory collapse, exaggerated hypotensive response to bleeding, more prone to perioperative shock, and therefore replace volume losses immediately in perioperative period. So this is why I asked him if he is a hypertensive, was there any need to reduce the dosage of your antihypertensives? This should be very, very commonly asked. If the patient is a previous hypertensive, you always ask them whether they require to reduce the dosage of antihypertensives. Coming on to the effect on renal system, there is a factors responsible for the renal shutdown or bile salts, endotoxins, inflammatory mediators. There is a decreased cardiac function which is resulting in hypotension, refractoriness to ADH, and increased levels of atrial natriuretic peptide resulting in hypovolemia. And this results in renal vasoconstriction, hypoperfusion, shunting of blood from cortex, activation of complement system leading to tubular and cortical necrosis. So these are all the changes that can happen. Similarly, immune system, there is a decreased cellular immunity and depressed function of Kupffer cells, impaired T cell proliferation, decreased neutrophil chemotaxis, defective bacterial phagocytosis. Because of all these things, patient can easily get infected. The sepsis can easily happen, especially when you do a paracentesis or something for removal of the ascitic fluid. You have to be very, very careful in the preparation. And of course, coagulation defect can happen because of all the coagulation factor deficiency, especially vitamin K dependent one. And thrombocytopenia, platelets also can be low, and you have loss of calcium. So calcium is also very important. And endotoxinemia, because bile salts act as a surfactants to disrupt endotoxins. So absence of, especially in the obstructive jaundice patients, when bile is not flowing into the intestine, there is an intestinal bacterial flora, they increase, and breakdown of GI mucosa happens. So translocation of bacteria will happen, and hepatic reticuloendothelial system function is decreased. So clearance of endotoxins is reduced. This is the reason for the sepsis or the translocation of bacteria causing centralized sepsis. So that is the main important function of bile salts. So patients with obstructive jaundice are more prone for bacterial sepsis because of this reason. Now, with regard to alcohol metabolism, it is metabolized by the usage of 4 enzymes. First enzyme is alcohol dehydrogenase, which converts it into aldehyde, and this aldehyde is transferred into the mitochondria where it is converted to acetate. And outside the mitochondria in the cytosol, there is a cytokine CYP2E1 enzyme is there, and there is another enzyme catalase. These 4 enzymes are involved in the metabolism of alcohol, and the pathways by which they are metabolized are oxidative or non-oxidative. And some patients where they, in spite of drinking heavily, they don't become cirrhotic. Some patients after a few years of drinking, they become cirrhotic because the genes of the enzyme determine this. So alcohol consumption, alcohol related tissue damage, and alcohol dependence all are dependent on the genetic code of these enzymes. So patients who have a lot of aldehyde, alcohol dehydrogenase and aldehyde dehydrogenase, they are able to metabolize most of the alcohol they drink. So they don't go in for liver damage. On the contrary, patients' enzymes who are weak in these enzymes, they go in for this problem because of the excess consumption. And this is the picture to show that. And this picture will be more useful. How alcohol hepatitis happens is, one is endotoxinemia, Kupffer cell activation is decreased and inflammation is there. Second thing is acetaldehyde formation and the adducts acetate, all these things got direct hepatocyte injury. And this cytochrome P2E1 oxidant stress happens. There is an activation of stellate cell the liver, which also results in hepatocyte injury. And there is a trigger of all the cytokines resulting in fibrosis. And because of the alcoholism, patients are not able to eat well. They gradually lose appetite and don't eat. And malnutrition causes impaired regeneration of the liver. So all these four factors, inflammation, hepatic injury, fibrosis, and impaired regeneration, all these ultimately lead to the cirrhosis. The various systems involved, already we have seen that, and based on that you have to do the risk stratification, of which the CPT scoring, MELD scoring were the original scorings, and then albumin level, platelet count, and ascites, encephalopathy, varices, portal pressure, all these things are taken because of patient related factors. The surgery related, emergency carries more risk than elective, and the nature of surgery, the duration of surgery, intraoperative blood volume transfusion, and the volume for complexity, all these things result in the decide about the outcome. Similarly, the demographic features like age, BMI, alcohol use, functional status, diabetes, comorbidities, congestive heart failure, all these things decide about the risk. And investigations we have to do is CBC to rule out anemia, and total differential count to rule out infection, PTINR to indicate the severity and prognosis. So this is one of the synthetic function which indicates the severity of the disease as well as decides the prognosis. Platelet count and its assay, LFT for albumin, enzymes, and bilirubin, and RFT for indication of volume status and HRS. And electrolytes, whether it's commonly hyposodium, hypopotassium, and hypomagnesium. All three can be low. And you do an ultrasound to find out the enlargement of spleen, which will be an indicator for portal hypertension severity as well as ascites. And nowadays we have a fibroscan to assess the stage of the cirrhosis by assessing the texture of the liver. And you have to do an EKG and echo, X-ray chest, all to rule out cardiomyopathy, pleural effusion, all these things. And risk assessment tools are assess the median survival of the patient, which is mainly CTP scoring, which took into consideration only the functions associated with the liver, like bilirubin, albumin, presence of ascites, prothrombin time, encephalopathy. All these things purely assess the liver function. So based on that, we can assess the mortality and morbidity. So this is how you classify. There are three classes, A, B, C. C is the most highest risk carrying score. Then another system was introduced, which is called the MELD score, which also helped in assessing the survival rate and also to decide who will be the first patient to undergo transplant. If a group of cirrhotic liver patients are there, who will benefit by doing an early transplant? That is also decided by the MELD scoring. So here, apart from the liver functions, they took into consideration the renal parameter also. So serum bilirubin and INR are the two liver functions, whereas serum creatinine is a renal work. So they combined all the three to assess about the mortality as well as the priority for transplant. So if you see this, when the MDLD score is 30 to 39, the predicted survival is only 40% for 6 months. So the patient will die within 6 months. So if you give priority to this patient, then he has a better chance of living rather than giving a patient who has got a chance to live for 24 months. So that in that way it helps to decide who should be operated first. Then the adopt LC score, which is considered as a more useful practical method of assessing, which is an acronym derived from adequate operated treatment for liver cirrhosis. And it takes into consideration four things: patient age, CPT score, as well as comorbidity score used by Charlson, and estimated duration of anesthesia. So these are all the comorbidities: cirrhosis with hypertension and esophageal varices, earlier myocardial infarction, congestive heart failure, any peripheral vascular disease, CVAs or dementia. These six comorbidities are taken into consideration. If all these things you can calculate, there is a ready reckoner which can be used by giving these answers. So if there is a 5-point total score, the mortality is after surgery. So this is mainly to decide the mortality following surgery procedure. So 8.9% of mortality will happen. And portal hypertension mechanism is commonly asked in the examination. So what are all the methods that causes the portal hypertension? You have to decide about the obstruction to the flow. There are two theories which are done, underfill theory and vasodilatation or overflow theory. So there is a cirrhosis which because of the constriction and damage to the architecture and structure, all the portal vessels are compressed, which results in mechanical increase in the portal pressure, which causes ascites, decreased effective volume, renal sodium is retained, and there is this tries to increase the blood volume. There is an arterial dilatation because of all the inflammatory cytokines that are produced, decreased effective volume. There is again a renal retention of sodium. All these things resulting in increased blood volume, resulting in ascites. So both the theories are being powder. So one is called underfill, another is called overflow theory. The sites of portocaval anastomosis and where esophageal varices can happen. This is another question you can expect. Lower end of esophagus, lower part of rectum, paraumbilical region. There are retroperitoneal connections. And sometimes patent ductus venosus, which is intrahepatic, which can cause a portosystemic connection. And hematemesis and melena in patients with portal hypertension, what do is you can treat it by vasoactive drugs like terlipressin, endoscopic confirmation, variceal ligation, sclerotherapy. If there is no bleeding, start beta blockers and complete the course of variceal ligation. Torrential bleeding, balloon tamponade for 24 hours. No torrential bleeding, further variceal ligation. All these things are the treatment for esophageal varices. And coming to encephalopathy, the root cause is liver failure. Liver failure alone in hepatic encephalopathy is rare. So it occurs mostly in acute liver failure patients. But in more chronic patients, the causes can be excessive nitrogen load like protein-rich diet, GI bleeding, renal failure, constipation, electrolyte disturbances, or sedatives and alcohol. Infection is another reason for encephalopathy development in chronic liver failure. And the treatment, sometimes they ask you how you treat a patient if he is going to stage 1, stage 2 encephalopathy. How can you prevent further deterioration? The treatment consists of diet, less protein load. That's very, very important. And then you can go for lactulose, non-absorbable disaccharide, 45 ml per hour orally. And lactose O-lacetol, 20% enema. These things will, until intestinal movement is achieved, and evacuate to remove all the ammonia from the gut. So this is more like a laxative. And then you can bind the ammonia by giving sodium benzoate or probiotics or ornithine. These are all available, 15 grams and oral 9 grams. Then N-acetylcysteine to replace the glutathione, which is also very important. So these are all the pharmacological therapies. And you have to give neomycin as an antibiotic to prevent translocation of the bacteria. And metronidazole, rifaximin, and flumazenil can be given if the patient's consciousness is battling between 2 and 3. Because it blocks the benzodiazepine receptors, and some improvement has been seen in patients given this. And bromocriptine as a dopamine receptor agonist is also used to maintain the blood flow to the liver. So these are all the treatment that you have to remember for encephalopathy treatment. And how does portal hypertension result in renal impairment? There is a splanchnic vasodilation, decreased effective circulatory volume, renal vasoconstriction to maintain blood flow, the loss of renal autoregulation, which is already caused as hepatorenal syndrome. So there is no functional damage in a until late stage. So initially it is a functional renal failure. So they say that if a patient with cirrhosis dies, you can even transplant his kidney if he has agreed that, because it is structurally okay. Because of the physiological aberrations, it is not working in the cirrhosis patient. If you transplant that kidney for a renal failure patient, it will beautifully work. So there is no contraindication for transplantation of a kidney from a cirrhosis patient. If he is willing, and before dying, you can take out that kidney. And again, the treatment principles are, in liver cirrhosis, liver transplantation is the ultimate treatment for hepatorenal syndrome. So until you replace the liver, it may not work at all. And then this is the mechanism which you have already seen. And temporarily, for some time, by instituting this TIPS what is that? Transjugular intrapulmonary shunt. It is just like your dialysis for your kidney. So temporarily you can reduce the portal hypertension by introducing this and salvage that, which will increase the vasoconstrict with and improve the circulation with vasoconstrictors and albumin. So this is a temporary, just like renal replacement therapy, you can try this to salvage the liver for some time until you can go for a transplant. So if you do transplant, ultimately you can succeed in reversing the hepatorenal syndrome with his own kidneys. And this is the changes that happen in the lung. So this picture is much more easier to understand. This is a normal lung with the alveoli, with the blood capillaries, the normal blood flow. When there is a hypertension, there is a vasoconstriction, vascular obstruction. So this increases the pulmonary pressure. And in the hepatopulmonary syndrome, what happens is there is a dilatation of the capillary and angiogenesis. So this is mainly shunting. Hepatopulmonary syndrome causes more of shunting. Portopulmonary hypertension causes increased pulmonary pressures, resulting in right ventricular inadequate function. Then hyperdynamic circulation, we have seen already why it happened, because of prostaglandin and interleukins. There is a vasodilators, cardiac output with decreased in SVR, reduced blood viscosity due to hypoalbuminemia and anemia also result in hyperdynamic circulation. Other serious changes are cardiomyopathy, diastolic dysfunction, which all result in hyperdynamic circulation. Then coagulopathy is a very common feature in all these patients. So how it happens, there is an imbalance. All the primary hemostasis, coagulation and fibrinolysis, which are all the three stages of total coagulation. All of them in our normal body, we have a balance between anti-hemostatic and pro-hemostatic factors. So that balance is tilted, and because the pro-hemostatic factors are less, you get always a tendency for more bleeding rather than thrombus formation. So how to optimize? Nutrition should be taken care of to maintain the lean body mass. That can be assessed by serum albumin, triceps skin fold and mid-arm circumference measurement. Hypoglycemia may be there because of decreased gluconeogenesis and glycogen storage. Hyponatremia may be there because of excess free water, and it has to be treated with aldosterone antagonist at a correct potassium level. Always keep a watch for encephalopathy, and the room air saturation may get decreased when the patient develops severe degree of HPS or portopulmonary hypertension. And parasympathesis may improve oxygenation because of the splinting of the diaphragm is relieved. But if you have to relieve or reduce, take out too much of fluids from the abdomen, then you have to replace it with albumin. In the olden days, they used to use a shunt to divert this, just like you are shunting for hydrocephalus. They used to shunt the peritoneal fluid directly into the splanchnic veins. That was called the Lee-Vein shunt, but it's not practiced anymore now. And optimization, continuing that correction of coagulopathy, you have to check the platelet, fibrinogen, and with the TEG. We have nowadays at the point of care testing can be done. And vitamin K can be given IV for 3 days, but also equip yourself with fresh frozen plasma, cryoprecipitate and platelet as per the advice given or the information you get from TEG, and prevent infection and sepsis with appropriate antibiotics, and transjugular intrahepatic potassiemic shunt in selected cases of refractory ascites or decreased renal function. So I told you this is a temporary measure like a renal replacement therapy to salvage the liver. And there is another thing, if it is due to toxin or drug overdosage, there is another method of doing the clearance by what is called MARS, molecular absorption recirculating system, which is also taking out the blood and passing it with albumin and trying to remove whatever toxins and reinsert the blood into the body. So whatever liver is doing, you can remove those toxins and drugs by using this MARS. What are the goals for anesthetic management? You have to preserve the hepatic blood flow. And what are the factors which are going to decrease the hepatic flow? If you know that, mechanical ventilation and PEEP. So keep the minimal PEEP, keep the lowest tidal volume to reduce that pressure. Avoid hypercarbia and hypoxia. Hypotension should be avoided. And the stress of surgery should be avoided by proper pain relief. And monitor and maintain renal function. That is the second goal. Prevent CNS depression and encephalopathy. That is the third goal. Prevent any coagulation abnormality. Correct it then and there. That's the fourth one. And maintain normoglycemia. That is very important. That's the fifth one. And preserve electrolyte balance. Then coming to anesthetic management, there is an alteration in the pharmacokinetics because of 3 reasons: increased volume of distribution, decreased protein binding, decreased clearance of drugs. Hepatic extraction and hepatic metabolism of drugs are reduced. So you have to be very careful in adjusting the dose. Induction agent of choice is propofol because it has got extra hepatic elimination. It also preserves the hepatic arterial buffer response and it has got a better recovery profile. Relaxant of choice is cisatracurium. Analgesic of choice is remifentanil but not available. So small doses of fentanyl can be used. Avoid morphine and pethidine totally. Inhalation agent of choice is isoflurane, sevoflurane, which preserve the hepatic arterial buffer response. Reversal, you have to give titrated doses of neostigmine because neostigmine is also metabolized in the liver. Giving a full dose of 2.5 mg can result in postoperative bradycardia and also muscle weakness. So monitors that you can use the routine ones plus the invasive one in severe cases like intraarterial line and CVP line. Regional anesthesia can be safely performed, but if the coagulation profile should be all right, and if the SVR is not too low, that is, if the diastolic pressure is not, pulse pressure is very wide, then it is better not to venture on a regional central neuraxial blockade. But low levels of block up to T10 can be safely managed. Coming to the post-op care, watch out for features of acute liver. Altered sensorium is the most important thing, and jaundice may look more intense after surgery. And monitor renal function and monitor coagulation, avoid infection, and paracetamol 2 to 3 grams maximum per day is safe, and local anesthetic technique for pain relief can be used. And coming to these are all the topics that you have to be well aware of before going to his exam. Histology of liver, about the hepatic lobule, portal lobule, and portal acinus, their function. Anatomy of the lobes of liver with the ligaments that can be asked, especially nowadays, liver transplants being done very commonly. Examiners may expect you to know the various anatomical and this coniad classifications of the lobes of the liver, which can be safely dissected out from a live donor and transplanted. And what are the mechanisms of control of blood flow, hepatic blood flow, bilirubin and bile physiology, and what are all the tests of liver functions you should be aware, and role of liver in drug metabolism. All these things is expected. The types of cases that you can get in the exam, it can be a clear-cut case of cirrhosis with portal hypertension, or it can be an obstructive jaundice either due to stone or a cancer head of pancreas, or it can be a case of segmental hepatectomy for secondary deposits, or it can be a ESD and stage liver disease patient for liver transplantation. And lastly, they may ask you about anesthesia for ERCP also, because it involves non-operating room anesthesia with the patient in a prone position sometimes. So all those challenges you have to describe, and what are all the types of anesthesia, sharing the airway, all these problems you have to know and manage. Now coming to this particular topic of obstructive jaundice, definition is failure of normal amount of bile to reach the intestine. That is the obstruction due to mechanical obstruction of the extrahepatic biliary tree or within the porta hepatis. So it can be intra or extrahepatic. And jaundice is a word from the French language. Jaune means yellow, and icterus is a Latin word. So if you say patient is not icteric, you are using Latin. If you are saying patient is not jaundice, you are becoming a Frenchman. So yellowing of sclera happens at 3 milligrams. Normally it should be less than 1.2, and up to 3 you will have occult jaundice. More than 3 you will have scleral yellowishness. And for skin and mucous membrane to become yellow, you should have at least 6 milligrams of bilirubin in the blood. And sometimes the beta carotene, that is eating a lot of carrot, or quinacin therapy, and can produce yellow discoloration. But the main difference is they cannot stain the mucous membrane and sclera. So they can produce yellow coloration in the skin, but not in the mucous membrane and sclera. And bilirubin levels commonly rise up to 3 weeks and then they stabilize. They don't go beyond that. And the bilirubin metabolism can be asked. So in the extravascular area, there is a breakdown of hemoglobin. And then from the heme, you get the bilirubin by the enzymes. And then it is attached to albumin, brought to the liver, conjugated, and through the bile it is delivered into the small intestine. And then from there it is absorbed back into the portal system. This is called the enterohepatic circulation, and part of it goes to the kidney and gets excreted. So the bile flow totally is 600 ml per day. The hepatocyte secretion is 450 ml. But the cholangic component, that is about 150 ml. So the biliary tree also secretes some amount apart from the hepatocytes, and the total serum bilirubin is 0.3 to 1.2 milligram per deciliter, of which conjugated bilirubin must be 15%, and the physiology of obstruction, what happens is normal secretory pressure of bile is 15 to 25 centimeters of water. At 35 centimeters, there is a suppression of bile flow. This high pressure leads to cholangiovenous and cholangiolymphatic reflux of bile. So bile gets reflexed from that into the blood circulation. Dilatation of the bile duct and intrahepatic biliary radicals happens. This dilatation may be absent if there is a secondary hepatic fibrosis or cirrhosis. So if the patient already has a fibrosis or cirrhosis, that is why majority of the time in cirrhosis you don't find jaundice at all, because of already the biliary canaliculae are all compressed, so they cannot dilate. And the increased biliary pressure, what does it do is it causes disruption of the tight junction between hepatocytes and the bile duct cells, which increase permeability. So there is a reflux of bile contents into liver sinusoids, neutrophil infiltration, increasing the fibrogenesis, and the reticulin fibers get converted to type 1 collagen. Laying down of collagen fibers lead to hepatic fibrosis. So the mechanism how jaundice can lead to fibrosis is this: the conversion of elastin, reticulin into type 1 collagen, and collagen forming fibrosis of the sinusoids and secondary biliary cirrhosis and portal hypertension. fibrosis can also lead to atrophy of the obstructed liver. So very, very late stages, you will get this sort of changes in obstructive jaundice also. What are the changes that happen in the blood flow? There is an acute obstruction, increase in hepatic arterial blood flow, no change in portal venous blood flow. So this will be a compensatory mechanism by which hepatic arterial blood flow will try to increase if there is an acute obstruction. But once the obstruction becomes chronic, there is a total decrease in the blood flow, dilatation of the sinusoid and elevation of portal pressure happens. So the arterial response goes on decreasing. That is the most important danger in chronic fibrosis or obstruction. Of course, the cardiovascular system, the contractility is decreased in obstructive jaundice, reduced LV pressure, impaired response to beta agonist drugs, in decreased peripheral vascular resistance, bradycardia due to direct effect of bile salts. Net result is hypotensive patient, exaggerated hypotensive response to bleeding, more prone for post-operative shock. So this is a very important change that you have to remember. Similarly, renal failure also is very common, 10% incidence with 70% mortality. The factors are decreased cardiac output, increased levels of ANP, decreased effect of bile salts on kidney mediated increased prostaglandin E2, which is responsible for maintaining the blood supply to the inner medulla, and endotoxemia. All these things resulting in renal vasoconstriction, shunting of blood from cortex to non-functional areas, activation of complement system resulting in peritubular and glomerular fibrin formation deposition leading to tubular and cortical necrosis. Now, immune system, defects in cellular immunity, all these things which happen in cirrhosis also happen here, decreased neutrophil chemotaxis, bacterial decreased phagocytosis, and depression of the function of reticular system, especially the Kupffer cells, which are the protective guards in the liver. They are all affected. And wound healing is delayed because of the incidence of reduced activity of the enzyme propyl hydroxylase in the skin, which incorporates the collagen formation is defective. So the wound healing also will be defective in patients with obstructive jaundice. And of course, coagulant factors are also very altered, prolongation of prothrombin time, loss of calcium, endotoxin damage, low-grade DIC, thrombocytopenia from hypersplenism, decreased absorption of fat-soluble vitamins. All these things contribute to the coagulation failure. Bilirubin per se, when it increases, it rises by 25 to 43 micromole per liter per day. What is the mechanism of hyperbilirubinemia in patients with obstructive jaundice is there is a biliary venous and biliary regurgitation of conjugated bilirubin due to disruption of tight intracellular junction of the hepatocytes. Then there is a transhepatocytic regurgitation due to reversal of the secretory polarity of the hepatocytes and rupture of dilated intrahepatic canaliculi and into the sinusoids directly due to necrosis of hepatocytes. So these are all the mechanisms. So increased pressure in the biliary canaliculi, rupture of the canaliculi, all these things lead to direct mixing of bile or bilirubin into the bloodstream instead of going to the intestines. Alkaline phosphatase is a very sensitive indicator in obstructive jaundice. The factors responsible are biliary component regurgitation and increase in hepatic synthesis of this enzyme, but they should always be assessed in conjunction with the gamma glutamyl transferase. Without that, it is invalid. The types of obstruction can be a complete obstruction, or it can be an intermittent obstruction, or a chronic incomplete obstruction and segmental obstruction. So the intermittent obstruction and segmental obstruction, you will not get a progressively increasing degree of jaundice. You may get a complete resolution for some time and then the patient may show signs of jaundice in intermittent and segmental obstruction. And the clinical points, how to investigate this ultrasound using to determine the levels and presence of intra or extrahepatic dilatation. The more sensitive will be a CT scan, especially in obese patients or if there is excess of bowel gas. and whether to assess the operability of the tumor, ERCP and PTC, and above all these things nowadays they use what is called endoscopic ultrasound, which is also very useful in doing both the diagnostic and curative procedures. Now, surgery is based on the pathology. If it is a choledocholithiasis, you can do an ERCP, remove the stone, or a CBD exploration, the bilioenteric anastomosis. Cholangiocarcinoma, as what he has described, liver resection and local excision, or sometimes Whipple's procedure may also be done. Biliary stricture, you can do a hepaticojejunostomy and liver resection. Periampullary carcinoma, invariably Whipple's procedure, and chronic pancreatitis with head mass, Whipple or bilioenteric anastomosis. These are all the possible surgeries for the extrahepatic obstruction that can happen. So the anesthetic management principles are almost all same for TCLD, except that you take extra precaution for protecting the renal function. And this Nutria is a pre-op carbohydrate drink, which is now recommended for all these patients to be given up to 2 hours to maintain some amount of intravascular volume, as well as reducing the gastric pH and improving the gastric motility. All these, so gastric secretion volume or pH not substantially different, but reduces thirst, hunger and fatigue, and reduces insulin resistance in these patients. So nowadays they give you as a part of the pre-treatment. And so that is all about the hepatic. Stop sharing, right.
Thank you, sir. Thank you
Thank
for
you.
a very extensive coverage of the topic, sir.
Yeah,
Thank you, sir.
I have become dehydrated. Thank you.
Thank you, sir.
Any doubts from the students regarding for the stimulating interest of the students? Can I ask one question, sir? How will you anesthetize the patient for tips?
Tips is it's only an intravascular, just like an angiography, or it's a mild sedation under fluoroscopic guidance. So it is not a major problem. So, but only thing it is something like an aura, not operative room anesthesia. So it is done in the radiology suite where you insert the catheter through the jugular IV and then go under fluoroscopic guidance through the portal, and it is creating a communication between the portal and the systemic circulation. So it is not a very painful thing. So mild sedation will take care of that.
Thank you, sir. And for one more thing, I want to remember here, sir. Today we have not touched much about the sepsis component of this cirrhosis and liver damage, sir. Like
no, sepsis, I have told immune responses.
yes, sir. Pathogenesis, cytopathogenesis, and pathophysiology.
Yeah, I told how the translocation occurs because of lack of everything I showed in the slide.
Yes, sir. And a patient with already existing liver damage gets into sepsis, then the mortality rates really jump up like anything. So are there any early markers of identifying a sepsis patient before taking up the patient for surgery, major surgery?
So this is only thing is you have to be very careful with your asepsis. Yes, and sir. Even the acute phase proteins may not increase high. That is one problem here, because they are also produced in the liver, like CRP or procalcitonin. They say is one of the important thing which can give a clue whether the presence of sepsis can happen or not. So you can't depend on your complement proteins and CRP, but procalcitonin definitely is a good marker of the possibility of sepsis.
It's also said they are kind of hypotensive all the time and they don't respond to the usual treatment of.
Yes.
That's a process. Yes, sir.
Yes. That is another challenge there. That is where they say methylene blue infusion can help. Where your noradrenaline and other vasoconstrictors cannot be of help. They have found that methylene blue can be of much help to restore the normal blood, I mean, vascular parameters, cardiovascular parameters. Especially after a clamp release in liver transplant patients. When your normal vasopressors don't work, methylene blue is found to be quite useful.
Yes, sir. And to increase the interest in the minds of the PGs, postgraduate students, for recent advances, there are some new markers coming up in the literature like mid-regional pro-adrenomedulin, neutrophil CD64, neutrophil dysfunction assay, and monocyte distribution width. And one more thing also, sir, neutrophil deformability test also. These are being added to the recent list of early identification of markers of sepsis in a liver failure patient.
Yeah, this may be asked if the student performs very extraordinarily brilliantly, then this can be asked.
Yes,
But they should not make any mistake in the basic fundamentals.
Basic
That is
fundamentals, yes,
more important than teaching them very high or recent advances.
Yes, sir. Yes, sir.
Yeah.
Sir, if no other questions and doubts from the students, can I put forward my request, sir? Next week, can we have a topic on biomedical waste management?
You said thyroid is
Yeah, clinical case presentation will be thyroid, sir. And theory question discussion, can we take biomedical waste management and
yeah, that is a commonly asked question. Yeah, that somebody can prepare that also. Yeah.
okay, sir. One thyroid case presentation and theory question answer for biomedical waste management, sir.
Yes, okay. Correct.
If no other questions from the PG students, can we sign off this meeting, sir?
Yeah. It's quite. I'm hungry also.
Thank you.
Thank you, sir. Thank you so much, sir. Good night, sir. Good night, students. Thank you.